My name is Peter Sandwall. I'm a board certified physicist at Ohio Health Mansfield. Ohio Health is a large hospital system in Ohio. There are 15 hospitals and we have 15 medical physicists. And one of the things that we do that is unique, maybe not, perhaps not unique, but was something that I had not experienced elsewhere, is that when we calibrate, we always calibrate with two physicists. It as visits from outside accrediting bodies, or they can be postal dosimetry audits, where we irradiate a dosimeter that we send back to a third-party lab that checks our calibrations. And this is all in the context of radiation therapy. And we have here a farmer chamber being irradiated by a cobalt unit. And just again, a little background about myself. I work for Ohio Health. I'm also a consultant with precision physics. I teach at North Central State College, and I'm a volunteer with Radiating Hope. I'm one of their board of trustees. So the objective of this lecture, and I hope unfortunately it is a lecture in this setting. I would much rather have a discussion, but there's so many of us. So I do encourage you to engage in the chat, and I might not get to it right away, but we will review the chat. And especially if you have a question, don't wait for it to fly away. Go ahead and put it in the chat when you think of it. I might not address it immediately, but it's important because the questions that you have are likely shared by others. So we want to understand the importance of reference dosimetry, independent audit, and independent audits in radiotherapy. But we're going to talk about the calibration chain. We're going to talk about the different audit programs. We'll talk about best practices and new developments. I'm also going to share some tragedies, so or maybe perhaps some events that we've learned from. So some audit findings. So quality assurance in radiotherapy. I believe I'm just reminding you all of the 5% rule. And that's the historical dose accuracy goal set by ICRU. And this comes actually from the fact that at 7%, the dose differences are clinically perceptible. A physician will notice a 7% difference in dose. And so we actually try to minimize that below that. And even now, we're reaching towards 3%. We think we can get even more accurate. And the value of that is as having good clinical trials based on good dosimetry so that we can make informed decisions about the treatments that physicians prescribe. So dose errors do impact they do have a clinical outcome. If you have a dose that is too low, you're not going to get the cure rate that you're aiming for. And if you have one too high, the toxicity rate will increase. So we'll talk about how calibration and audits fit into a QA program and kind of really stress their importance. So let's talk about reference dosimetry. So when we do, and that's what we as clinical physicists perform, is reference dosimetry, is we are performing dose measurements under reference conditions. I don't like the term absolute. I'm a little pedantic. This means that I'm very precise with my words. There are very few absolute dosimeters. An ion chamber is not one. Fricky dosimeters, calorimeters, and chemical dosimeters are absolute dosimeters. These we do our best to calibrate them so that they're accurate, but they are reference. They are referenced back to either a large free air ionization chamber or calorimetry, which is the measurement of the change in heat. So calibration of the Linux output is performed using a standard ion chamber. That ion chamber is traceable back to national standards. And it actually starts at this Bureau of International Points of Measures. And this is in France. Then from this standard, it goes out to different primary dosimetry labs. And then from there, it goes to accredited dosimetry calibration labs. And then from there, it goes to the clinic. There's a chain. There's a chain that, and this is where, again, understanding the uncertainty. Each time you pass something down, there may be a little bit of uncertainty added, and we do our best to minimize that. But when we get when we get an ion chamber, that typically has from 1 to 2.5% uncertainty in the NDW. This is something to consider. A lot of this is outlined in this summer school text from the AAPM. This is from 2009. This is one of my favorite books of all time. I highly recommend it. So how does the calibration chain work? Kind of mentioned it already, but it starts with this international lab, and then it goes to primary labs, the secondary labs, and then to the clinic. Each step transfers a known dose with uncertainties. And this is giving actually the uncertainties from the different labs. And you can see here the values that they're getting. And then you see the error bars, the range. Now this is still very small, but it's not zero. I think this is really important to appreciate, that there's always uncertainty in all of our measurements. That's why I'm very sensitive to the terms absolute. It's still relative. It's just relative to a standard, and we've done our best. We've worked very hard to make that range of uncertainty very small. So clinics get the chamber factors, the NDW, from an accredited dosimetry laboratory, and we either use TG51 or TRS 398 to actually calibrate our machines. So I am aware of my Western bias. I am from the States, so I know TG51. I do not know TRS 398. This would be probably something good for me to learn.
Okay, listen.
But the way that TG51 works is to get the dose in water, the dose for the specific energy, Q, in water, we have to multiply our measurement, our corrected measurement, I should say, by the KQ, which is the quality factor for the energy, times the NDW that is provided by the calibration laboratory. Our corrected measurement is dependent upon the performance of the ion chamber itself. There's ionization, there's recombination, there's the temperature, pressure, there's the electrometer, there's the polarity, and then obviously we use the raw reading corrected to get this value. So there's a whole chain, and then I think the temperature and pressure is one of the most important to be sensitive to, and we'll talk about that, is that some people might not have access to calibrated thermometers or barometers, and this is something that really is important. It's essential. This has actually led to a lot of errors, is using the wrong barometer or using the wrong thermometer, and we'll talk about that. We'll mention some specific cases in which this has occurred. So the way that the ADCL, these accredited dosimetry laboratories, the way that they actually verify that their equipment is working, that their calibration is correct, is that they audit each other. And they audit each other through these, what's called a round robin audit. Sorry for that, there's a loss in resolution, but this one in the lower, you can see this is actually, they're looking at sources, but it's the same process. NIST, which is the National Calibration, the primary calibration laboratory in the United States, they will calibrate an ionization chamber, and then they will send it out to all the different accreditation laboratories, and we have 3 in the States. We'll send those out, and everyone will do a calibration of the same chamber, and then they'll do a comparison. In the same way, the IEA dosimetry lab will do this. Will do that with their secondary dosimetry laboratories. So they'll use one chamber and they'll see what this person gets for NDW, they'll see what this person gets for NDW, and they'll be able to assign a measurement uncertainty or a calibration uncertainty. And this ensures that there's no bias in any particular lab. And it's a way of cross-checking each other. And it's the same thing that we're encouraging ourselves to do. I say ourselves because I'm not saying what you should do. I'm saying what we should do. This includes myself. So this calibration chain and dosimetry standards, this is my first question. So I want to make sure you all are still awake. I cannot see the chat, but I want to enlarge in that. I do not have, I believe there was built into this, let me see, there's the chat. I believe this was built into this, a Zoom poll, but because there's not, I'm going to ask that you all privately message me. So I want this to be a private message to me, your answer to this question. Why is traceability in the calibration chain crucial for ensuring accurate dose delivery in radiotherapy? So the choices are, A, it ensures that every clinic applies the same correction factor to their machines. B, it provides a direct link to national and international standards, minimizing uncertainty. C, it eliminates the need for periodic recalibration. D, it allows physicists to use any ion chamber without needing verification. Good, I see several. I see people are being courageous. So, yes, oh, okay. I like this one. I like A and B. So I shared that I teach. So I teach physics at a community college. And I know that when there are one of the choices that is wrong is very commonly selected, that means that it's an ambiguous selection. So A is an ambiguous selection because we don't want you to apply the same correction factor. But what we do want to do is B, as provide a direct link to national and international standards, minimizing uncertainty. So what I'm admitting is the fact that A, I may not have made A wrong enough. It is right. You want to apply the correct correction factor. You want to apply the right correction factor, but it's a little ambiguous. So I can improve that next time. So traceability ensures that dose measurements at a clinic are aligned with international calibration standards, reducing variability and maintaining consistency in treatment across institutions. So a large number of you got that correct. Many of you were led down the wrong road by my tricky question writing, but I don't intend to trick, so my apologies. All right, Janet, am I moving at a reasonable cadence? Okay. So let's move on to number 7 as we're moving on in our discussion. So we've got a couple more of those checkpoints just to make sure everyone's engaged, but we've got a fair amount of information to cover. So these are the information dense slides coming up. So dosimetry audits, why and how? So external audits are independent eyes. It's always good to have a second check, so somebody else to look at the work, and they allow us to catch the errors. There are different types of audits. There are the postal, where we get TLDs or OSLs mailed to us, and then we irradiate them and send them back. And then there's the on-site audits, which is where physicists or other professionals will come and visit with their own equipment and check our work. And I also want to be clear. Those on-site audits, they don't have to be by a large organization. They can be by your friend in the next community. They can be by your friend across town. They can be by a colleague from the States or Europe, but they can also be from a colleague that you work with that works at a different center. And that's what we do at our centers in Ohio. There are 15 physicists working at all different hospitals, but when it comes time for calibration, somebody else comes and we do it together. So we have a second pair of eyes. And that would be considered, or that could be broadly considered an audit, a second check. So audits range from these basic output checks, which are essential, to full end-to-end tests using phantoms, such as this head and neck phantom from MD Anderson. So that dosimetry intercomparison, where you're using different equipment versus an audit, those expressions are often used interchangeably. This is some data from MD Anderson, and it shows the variability. This is from 16,000 different audits, dosimetry audits, and it shows the variability. A large range of people are within plus or minus 5%. But there are some cases that are as much as 10%. And so, as we mentioned earlier, 10% is significant enough to be noticed. The physicians are not going to get the cure rates they expect. And in the case of 10% high, they're going to get increased toxicity. So this has very real impacts to patients. This cumulative pass rate by date, these are pass rates for these end-to-end tests. And you can see there's all phantoms. They get about an 80% pass rate. The head, they get about 100%, or mostly 100% pass rate. The liver, I've done the liver, it's tricky. I'm not sure what went on here, but the liver one is very hard to see. Then the prostate, it's about a 70% pass rate, and the spine about kind of roughly the same. So these are people that feel confident enough to ask for outside review, and they're not always perfect. And sometimes those mistakes, I've made them myself, are due to an incorrect IGRT shift. Maybe you didn't move the couch up, or something like this occurred. They happen. That's why they're important. It's important to perform them so that you can become aware of what the potential errors in your process may be. So these are the key audit services. The IEAE has been doing postal audits since the 60s. They've been doing this for quite a long time. The IROC has been doing it since 1968, so they're not far behind. Their Astro Equal has been doing them since 1998. And there are national programs, and I see that as one of the questions about Africa. And I think I'm not aware off the top of my head, but we can look into that, and we can talk about getting them we can look into that, and I see this as a direct message, so I can address that. So one of the things that these audit services do is they help support clinical trials so that we can make informed decisions about the doses that we're treating. And IROC in Houston, they are one of the foundational elements for all the different clinical trial networks in the United States and Canada. They really help ensure that the dose reporting is homogeneous. And I know that this is also what Estro's Equal program is doing, is working to ensure that the clinical trial data has high integrity so we can make truly informed decisions. So the AAPM in the States accredits the secondary dosimetry calibration laboratories. And one of the things that they do is they set the standard for calibration. So we all do TG51. They also set standards for the quality of the chambers that are used. So this here below the logo is a list of things that will cause a rejection of an ion chamber. If it has a calibration coefficient that differs by more than 1% for gamma or 2% for X-ray. So this could be due to the flaking of the interior wall. There can be different reasons for this, but if your chamber calibration changes significantly, this is likely due to a change in the mechanical integrity of the chamber itself. And it also talks about the collection efficiency, that it should be 99%. The ionization chamber leakage charge should not exceed 1%. Oops. And then if an air vented chamber does not equilibrate with ambient pressure in a minute, it also may be subject to rejection. So they have these very clear criteria, in which case they will take a ion chamber out of service. They will say that this is no longer a reliable measurement device. We don't want to be calibrating our machines with this and treating our patients based on that calibration. What the AAPM also does is they set standards for those dosimetry calibration laboratories to achieve. So you can see here that the NDW, the uncertainty should be less than 0.8%. There are some other items in there, so they're saying less than 1.4%. So if a particular calibration laboratory is getting, when we talked about that round robin, if they come back with a chamber that's 2% different from the other laboratories, their processes will be subject to scrutiny, will be investigated, and they'll try to bring them back in line. But again, the AAPM in the States, they have a very clear role in setting the quality standards for these calibration laboratories. So let's talk about the IEAE a little bit. So they've been doing this for a long time, since 1969, which is pretty amazing. So they've got a lot of data. They have their secondary dosimetry calibration laboratory network is about 80 labs. It's a lot of different calibration facilities. And their emphasis is on the countries that don't have anything and trying to ensure global harmonization. We want to be able to be confident that we're providing the patients with the same dose, so that when we read literature from the States or from Asia or from Europe or from Africa, that when they say 50 gray, they mean 50 gray. So that's very important. And this is really why we're so sensitive to this. These are some of the things that they've learned auditing over such a long period of time. So in this corner here, this upper left, they show that after the first check, this got significantly better. You can see from 1990, the first check was about 63% were correct on the first time. And now we're up into the 90%. Not so great. That might be a 97% getting it right the first time. Always after the second check, after the follow-up, there's been an improvement. So this has been showing that we've been converging on unity. We've been getting closer to harmonization of our dose calibrations. They found some other interesting things, and you can also see this in this one on the right. That again, you're seeing a convergence. You're seeing tighter banding. You're seeing that whereas in the early audits, they were all over the place. And then slowly, there are still outliers, there's still mistakes that are made, and none of us are immune to them. And that's an important thing. And that's something that I don't love to share it, but I think it's important to share it. I have made mistakes. I have miscalibrated. And fortunately, due to good processes, I've been able to catch it in a quick period of time. What it takes to really catch it, and to catch it quickly, is to have a second pair of eyes. Don't think that we're all smart. We're all physicists. We're not immune to mistakes. So this is why this is important. These are some other things that they learned. Here, the age of the machine matters. The blue is cobalt. The gray is a linear accelerator, you see that the older the machine, the more variability there is in the calibration. With linear accelerators being less reliable with time than cobalt units. And we'll talk about how cobalt units also have calibration errors. You see here in this bottom right corner, and these are showing the kind of the percentage of results within 5% limits in the different regions. And what you see, and this was surprising to me, you see that the cobalt 60 units are actually calibrated incorrectly more often than the linear accelerators. This was a really surprising thing to me. And I will share a vignette about something like that occurred like this. But it's interesting. So again, just things to be mindful of. We think cobalt 60 unit, oh, of course it's going to be calibrated correctly. That's just cobalt, but errors can occur and do occur. All right. So we mentioned the postal audits and these pictures down in the lower left. Those are postal audits from MD Anderson. That block includes OCLD or OSLDs or TLDs. And then over here you have a head phantom. This is actually where they've got a tumor and different things embedded in there are both film and OSLDs to do an end-to-end test. This abstract from 2015 talked about how RPC has branched out and now perform these audits internationally. And this was in 2015. That by that point they had done 43 different countries. They've done the OSLDs and then also head and neck phantoms. And I want to highlight this because this is important. This is something that's good. So of 182 international patient charts reviewed, 10% of the dose calculation points did not meet our acceptance criteria, as compared to 13% for North American sites. So, and they have a reason. They say that it's due to HDR, but they also the international sites actually had a little bit better than the North American sites. So this American didn't say, oh, we know. This is encouraging. So other programs, and so UK and Europe, they have regional audits through the IPM. There's MPL reference, again, Estro Equal, which we mentioned, the different trial, other RTTD QA for trials. There's also the Australian program, and they have a 4-level audit structure. They have level 1, which is just the TLDs or OSLs, which is the postal dosimetry. They have level 1B, which is an on-site cross calibration or calibration with a different set of equipment, and it's offered to new centers prior to opening. So what they'll do is they'll send a physicist over to verify or add increased confidence in the calibration that's been performed. They have level 2, which are detector array, dose distributions, something like an IMRT QA. Maybe they'll send over a plan and then have them see what their results are. It's interesting. I think that a lot of Australian centers, they not only use they use reference beam data. They use the same beam data for accelerators of the same model. So it's very reasonable to expect an IMRT QA in Sydney to get the same result in another city. Then level 3, then they'll do, that's an anthropomorphic phantom, such as the head neck phantoms or pelvis phantoms, and that'll be a complete end-to-end test. There are now also commercial audits. This is something we use in our system. We use this for when we commission all of our SRS systems, and then annually thereafter. We do end-to-ends on an annual basis. And this is with the RT Safe Phantom, which is actually an insert with a polymer gel. So the way that this works is it's a gel embedded with a bunch of monomers. It's irradiated, it polymerizes, and then that's viewable on an MR or an optical scanner. We use MR at our place, but they have options. And this is a very good three-dimensional test. And yeah, full disclosure, nothing to disclose, but maybe a little bias that I did do research in gel dosimetry, and I think it's cool. It's hard though. So let's pause. Let's make sure that we're all on the same page, and let's do another check-in. So here's the second question. What is the primary purpose of external dosimetry audits in radiotherapy? So A, to identify and correct calibration errors before they impact patient treatments. Or B, to replace internal quality assurance programs. C, to certify physicists for clinical practice. Or D, to provide a theoretical assessment of treatment planning software. And it looks like Emily jumped in and helped us out, and she has created Zoom polls. So you should be able to answer this as a poll. I don't know if this popped up for you, but go ahead and answer the poll.
Yeah, just jumping in too, Peter. Thank you, Janet. Thank you, everybody, for going with the flow this evening without a moderator. So if you need anything, Peter, just let me know. And I think the poll popped up for everybody. So we have about 40% participated so far.
Yeah, sorry you had to jump on. I know you were traveling. So, and thanks for getting the polls together. I gave it to you, but late.
Not a problem. Okay, it looks like we're slowing down a bit at 40%, 45% participated, and I think I will end the poll and share the results so everyone can see that most people selected A.
That's great. So, and I like 88 is a fortuitous number. So the majority of you got this, and that is to identify and correct calibration errors before they impact patient treatments. So when you're commissioning a machine, and it's especially important to get that second check, and then annually thereafter is ideal. I am sensitive to limited resources, but I do want to stress the point that an audit does not have to be from someone outside the country. It can be from someone within your region, and it can be one of the things that I like to do if I'm cross-checking a friend that doesn't work in my network is let's trade Excel sheets. Let me use your Excel sheet, you use my Excel sheet, and we check, because the Excel sheets are also prone to error. It's not just that that our chamber is off. It could be that a value in our Excel sheet has changed, and that has led to an error. So moving on, best practices. And I just added this French translation on the fly because I didn't know there was going to be a bunch of French speakers. Otherwise, I would have had a lot of this in French, because it's easy for me to speak in English. And I know it might be easier for some to read their native language. But I do want to emphasize this point that a physician's mistake is personal. They make a mistake one patient at a time. A physicist's is universal. When we make a mistake, it affects all the patients at once. So it's very important that we're very careful with our calibrations. This is the most important thing we do, and the last thing we want to do is hurt someone. So things that we can do to protect ourselves: we calibrate annually and after major changes, use independent secondary checks, whether they're another human or a postal audit, follow the codes of practice to the letter. You want to do this, you want to make it so that you're following the rules perfectly. And I want to be clear that you all are scientists, and you all have independent minds, and you may question the validity of different things. But G.K. Chesterton was a kind of a philosopher who was a clear thinker. And one of the things that he's known for is Chesterton's fence. You don't ever take down a fence till you know why the reason why it was put up. So don't ever change a process until you're very clear on what that process is doing, why that element is there. So the way we protect ourselves, especially early in our career, is following the letter. Just follow it perfectly. We want to keep all of our chambers calibrated, understand the uncertainties, and write everything down. So if you do make a mistake, God forbid, you can figure out why and you can learn from it. So it's essential. And I mentioned the fact that I've made mistakes. My mistakes have been with Excel. I've made mistakes with where things are pointed. And fortunately, they have not been large mistakes. But that's not to say that I just didn't get lucky. So be careful, follow the codes to the letter, and get someone to check your work. So auditing, again, you don't wait for problems. You get those audits scheduled proactively. There are different types of audits. They're not just the dosimetry audits, but they can be process audits. In the States, we have peer review of clinical medical physics. And when I was an independent consultant, I, out of my own pocket, paid my friend to come and spend a day going through my system, like check the work independently. And you're going to want to make sure that it's someone that you trust, someone that's going to be ethical, someone that's going to that not just going to give you a blank check, but someone that's going to hold you to task. So prepare and cooperate fully during these audits. It's not police. They're not coming to bust you. They're coming to help you. We're all in this together to help others. So they are there to help you and to help improve your center. So any discrepancies, you can fix them and learn from the reports that are provided. And if you can engage with your local physicist, this is best. And there are lots of different audits in the States. And then there's this Quattro this is an IE8E document, but this actually goes through, it has a checklist and it gives you the processes for conducting audits. There are other audits for specialized treatments such as radiosurgery. And I think that those are also of extreme value. I don't know so much about brachytherapy audits, but I do know there's some publications on them out of Japan, and Japan, which we I think, or at least I hold them to a high degree of quality standards. There were differences there were calibration errors across sites in Japan. So nobody's immune to these things. It's important that we accept that, and so we stay vigilant. So now this is the kind of the rough part. This is a little bit of but this is it's important to learn from others and to learn from the past. And there have been some serious mistakes in the past. So the first one I'm going to start with is Columbus, Ohio. This is my health system. The Riverside is our primary site. And I had a retiring physicist just give me this book. I don't know if you can see it in the chat, but in the top corner, it's signed by a physicist. I'm not going to put out his name. He's deceased at this point. But this was not a person who did not care, but this was a person who was working very hard, and he used the wrong graph paper for his cobalt-60 decay. So what this did is this led to significant overdoses, and it killed people. So you got to think about the weight of that this individual had to carry. Nobody wants that weight. There are reasons for the mistakes, but I would say one of the biggest reasons was the fact that he was practicing alone and didn't have anyone to check his work. I think many of us have heard about Therac. This was a software error, and this was also fatal to people. There was a miscalibration in Spain on a Sagittaire Linac. Again, this This led to deaths. This is a serious event. Springfield, Missouri, a commissioning error. They used the wrong field size factors. They used farmer chamber. So this was not fully in the treatment beam. So they miscalibrated it. And again, this led to significant overdoses. So you got to think that's probably led to a lot of radionecrosis and increased toxicity. Another commissioning error in Tampa. This was due to the wrong PDD factor used. Again, significant overdoses. And I'm highlighting the fact miscalibrations, commissioning errors. Again, this goes back to a physician's mistake is personal. A physicist's is universal. These things are not good. Then these other ones in 2005, 2006, these were some events that were highlighted. There was a series of articles in 2011 in the New York Times that highlighted that some of the dangers in radiation therapy. And this one's due to MLC files, and the other one is due to a plane calculation error. These are some serious things that can be caught, hopefully caught before they cause too much damage. So let's dial into some particular vignettes. So
Hey, Peter.
yes.
Do you mind if we jump in with a quick question before getting into some of the?
Sure.
Thank you. And apologies if you are coming up to this, but I just want to ask, what action should be taken after an audit which finds serious errors for the physicist in the structure?
Serious errors, say that's the last part.
Yeah, what action should be taken after an audit which finds serious errors for the physicist and the structure? And also my apologies, I used Google Translate for French on that one. So
that's fine, and I think that might be I'm assuming by structure the departmental errors or maybe process errors. I mean, ideally you will work together with your team members, because radiation oncology is a team sport. So we don't operate alone. Even when we're the sole physicist, we work in communion with our physician and with our technologists. So if you get an audit that has a serious error, you should investigate it. Investigate it to determine that it's real. And I want to be clear about that. Sometimes those reports or those TLDs you get back, the results from them aren't always accurate. So you do not use them for calibration. You use them to check your calibration. So if you see you get an error, let's say a dose outside of 5%, first thing you do is you try to figure out if that's correct, if there is an issue there. And so what you would do is use a second set of equipment, and ideally a second person. So bring in some independent eyes. And sometimes if you have a structural or system or departmental issue, it's best if the suggestions for change come from outside. So if I had a postal audit that came back with something that was wrong, I would recheck the output with a second physicist. And if I had independent auditors come in and say that something needed to be changed, as a group, I would hope that the team would look at those suggestions with an open mind.
Thank you.
All right. So these are some events that occurred. And these were from the last person who gave these presentations. He had these in there. And Frank Ascoli, he also went to the University of Cincinnati, and we once shared a meal together. But he went to school with my advisor. So dosimeter calibration report was used incorrectly. And this is actually a case where someone overthought it. And we are prone to do this as physicists. Many of us can overthink things. So the institution had its ionization chamber and electrometer calibrated for cobalt-60 at the Standards Dosimetry Laboratory. The calibration certificate was in terms of dose to water. You can see this absorbed dose to water calibration. This is the NDW, but was interpreted as specifying dose in air. And I think that there can be I can see how the logic could come about from that. Well, they're calibrating ion chamber. The ion chamber is filled with air. It's not filled with water. So they did a conversion to they applied a conversion factor to this. Essentially they converted Rankine to rad, and that led to an 11% overdose of patients for at least a year. So the initiating event calibration error, it was an incorrect use of calibration certificate. Contributing factors, insufficient education, training, or expertise. The physicists did not seem to understand the calibration certificate. I think this is yes, but I would be a little, yeah. I would hope that this person, yeah, I guess they were not instructed on how to read this calibration certificate. But if there was questions, one of the things is I would hope they would be able to discuss them with someone else. So I think this is actually, that's a fair statement. If they were a junior physicist, maybe talk to the senior physicist. Insufficient safety provisions. There was no independent beam calibration by another physicist. Again, this is why a second pair of eyes is really important. All right, here's another one. Incorrect use of a plane parallel chamber. So a new physicist at a hospital used a plane parallel chamber to calibrate several electron beams. A label on the chamber placed by the previous physicist indicated the side on which the beam should be incident. Although the previous physicist had used the chamber correctly, his labeling was incorrect. He put the label on the wrong spot. He knew where to put it, but there was no transfer of that knowledge to the new physicist. And so when the new physicist used the chamber, he used it upside down, resulting in several errors in beam delivery. So this is the plane parallel chamber that was used. There's a thin window on one side, but there's buildup on the other side. So the reading that you get from the front is different from the reading you would get on the back. And this is so for the lower energies, it was most significant. For 6 MV, it was 20% overdose because it expected a higher reading, so he turned it up. 9 MV, a 10% overdose. 12 MV, 8% overdose. 16 MV, it happened to be in the sweet spot, so it wasn't that big of a deal. And same with 20 MV, 1% underdose. And that 1% you might even call noise. But these other ones are quite significant. These are the ones where you're going to see a clinically significant difference in outcome. And in this case, if you're treating electron beams that are 10% hot, you're going to get a lot of breakdown on the skin. You're actually going to cause significant physical harm to the patient. So there were a couple things that initiated this. There was the incorrect use of the plane parallel plate to measure the electron beams, but the contributing factors were this individual did not know how to use that chamber. So they used the chamber unfamiliar without verifying the proper technique. And always get the manual for a new chamber, whether it's a PTW, a standard imaging, XRAD-in, or whatever chamber. I'm sure there are others that I'm unfamiliar with. Get the manual. It's very important. There have been other mistakes that I'm not going to talk about today, but that have been due to the material composition of the chamber. So different materials respond differently and measure differently. So there was not a good handoff. There was not a good transfer of information. I was either doing a miscommunication or there was just the information was not shared effectively. So this was corrected with the chamber properly oriented. The label of the chamber was corrected, and fortunately, not a lot of patients were treated with those beams. However, it's not a good outcome. So it's not a good occurrence. But now we learn from it. So here's another one. Event 3, an error in correction for atmospheric pressure. This is a classic one. We like to use this as a board question, but an institution did not own a barometer, and the physicist relied on the local airport for measurement of atmospheric pressure. Pressure reported by the airport is corrected to sea level. It's not at the local altitude. So the physicist interpreted the pressure report as appropriate for the elevation of the site, about 1,000 meters. And so the incorrect use of the incorrect pressure resulted in errors, which caused a 13% overdose to patients. Again, increased toxicities. So the airport gives you this pressure that's to sea level, You want the pressure that's corrected for altitude. This is another opportunity for cross calibration. If you're going to use a different barometer, and I know it's very popular now to use the barometers on cell phones, cross-check it, validate it, make sure that the reading you're getting is the reading that you expect. This is another reason that taking good notes is really important, so you can look back and see what the pressure was over time. Eventually, after you've done calibrations in your area for 5 to 10 years, you're going to know what the pressure is within some variation due to weather. But if you're visiting a new place, especially if in a place of a different altitude, you may get a significantly different pressure reading. And it's important to be that you have good equipment, ideally calibrated equipment that gives you good values. So in this case, it was a calibration error, and then the contributing factors were shortage of instruments. It didn't have its own barometer, so we was using the airport one without the knowledge that you need to do the altitude correction. So this one's another one. This one's actually got several things baked in, and actually it addresses some of the question earlier, because this isn't just the physicist. This is also the system. This is the human system of different individuals that are working in this place. So 3 radiation oncologists and 2 physicists worked at 3 affiliated hospitals. Each person worked in at least 2, sometimes 3 of the hospitals. There are 2 sets of calibration equipment, ionization chambers and electrometers, usually assigned to a particular hospital. The 2 sets of equipment were never intercompared, although they were used by both physicists. So we could see there was not an opportunity. The intercomparison could have caught this sooner. So a review from an outside physicist. So they had an independent audit. Showed a discrepancy of up to 15% between measurements made by the 2 sets of equipment. So one of the sets of equipment was broken. It was giving the wrong reading. So after discussion with the physicists and radiation oncologist, it was learned that one of the physicians had noticed the difference in clinical results in the 2 hospitals. He was paying attention, and he knew that he was getting different results. And he had corrected for it independently. He did it on his own by prescribing 70 to the prostate in 70 grade to prostate in one hospital and 60 grade in the other hospital for the equivalent treatment. He knew that there was something off, and he corrected for it. But this was a system problem because he didn't share this with his colleagues, which is really unfortunate. But that incorrect calibration, where the wrong calibration factor was used, there was a lot of things that were contributing to this event. So there was ineffective procedures. So there were different calibrations, but they were never intercompared. If you have two sets of chambers within your system, one of the first things you should do is at least see that you get reasonable results. They should be within 1% of each other. There was ineffective communication. The physicians failed to share what they had noticed. And I don't know what the cultural or personal barriers to that communication were, but it's very important that we as physicists, and I know that I presume that there are physicians on this webinar. It's very important that there's a relationship between the physicist and the physician. And I see myself as a clinical consultant that is there to help and support the physician. I'm not just there for the machines. I'm there to support the physicians. And I think that's a very important relationship. So unfortunately, rather than discuss the problem, at least one clinician, they handled that discrepancy with a correction factor. And that was a very interesting finding. And but it's illustrative of things that can happen. And so it's not always possible. Best way to do things, though, is have a colleague come independently check your Linux with their own equipment. And if they're your good friend, you just get a pizza and 6-pack of beer, and you guys do the calibration. Maybe just one beer till it's done. This is the last question, because we're rounding the corner to the end. So, learning from common calibration errors. One of the case studies in the presentation highlighted a physicist using a plane parallel plain parallel chamber incorrectly, leading to dose errors. What was a key contributing factor to this mistake? A, the physicist ignored the calibration certificate. B, chamber was improperly labeled by a previous physicist, leading to misinterpretation. C, the physicist deliberately used the incorrect technique for testing. D, the error was due to an inherent design flaw in plain parallel chambers.
All right, we're seeing the answers come through so far. We'll give it another few seconds. All right, 30% participation. Let's see if we can get up to 40. All right, I think that's good. So I will end the poll. And this is a pretty interesting distribution.
Oh. Well, I think that the reason for this distribution is because we had several vignettes. And the last one that we just discussed, the calibration factor was they used the wrong calibration factor on that equipment. But it was not that they ignored the calibration certificate. In that plain parallel chamber mistake, it was that it was improperly labeled and there wasn't clear communication. There wasn't a clear handoff. So most of you, the majority, got this right. I see how where this other distribution came. And I honestly, C and D, C is correct, but not deliberately. So incorrect there. Let's not assign any malignant attitudes to people. Look, most people, when they come to work, they're trying to do their best. They care, and sometimes they make mistakes. But I think it's very important to always look for the best in people, because we find what we look for, whether it's bad or good. And then the D, the error was due to inherent design flaw in the plain parallel chambers. I actually kind of like that one. I see where you're going from, because if you could flip it, if you could flip it without it changing, then that would be kind of cool. But it was mislabeled, so that was the correct answer. And it underscores this importance of clear communication and training in the calibration procedures. This person did not know about that chamber, and so they just trusted this little note that was placed on the chamber instead of actually looking for the documentation of the chamber. It's important to get the documentation for all new equipment. Again, this emphasizes the need for peer verification and documentation. All right, we're getting near the end. This is the new developments in dosimetry standards. So TRS 398, published in 2000, has not changed. It is pretty solid, and I would expect that many of you in Africa and the Middle East are using TRS 398 just due to your proximity to the IEAE and probably relations with the IEAE. I do use AAPM TG51 that came out in '99, and there have been a few updates. One just last year, first in 2014. I would recommend these as reading material. You don't have to adopt these protocols, but there's a lot of knowledge in them, especially these addendums. The first addendum, they talk about energy or uncertainty budgets. And I mentioned this earlier in terms of you've got this chain of dosimetry, and each point along each link in the chain, there's a little bit of uncertainty added to the process, such that the best you're going to do is have chambers that are about within 1% of each other. But it talks about the uncertainty in your own setup and measurement. And in fact, we had a student set up and recalibrate, set up and recalibrate, set up and recalibrate. And their measurements were within roughly 0.7% of each other. So that means each time you break down your tank and you set up your tank, even there is going to be uncertainty. So understanding that is important. Then this latest one, this one for electron beams, it also has some nice things, some subtleties that are specific to TG51 that I won't get into, but these are good reference material. So audit technology has improved. The OSLDs, more and more people are using OSLDs. rather than TLDs. There are some advantages to OSLDs. There's some disadvantages. They're not perfect, but one of the cool things is you can take multiple measurements, so you can you have some better reduced uncertainty in their readout. 3D phantoms are more and more common in gel dosimetry. I mentioned earlier RT safe. That's from a group of Greek physicists. Ahead of his time was Mary Ansky, and Mary Ansky was one of the inventors of gel dosimetry. He tried to sell auditing services early, but the technology wasn't there, and he really didn't get the adoption that RT safe now has. Sometimes an idea is ahead of its time. But there are more and more audits for IMRT and VMAT for more and more end-to-end. There you can see here a whole series of different phantoms. You have pelvis, head, neck, spine, SRS head, thorax, liver. And all these are leading to more global collaboration. The more confidence we can have in a sister institution or cousin institution, the more we can collate the data and get some good, hopefully, data that informs clinical decision making. So the impact on audits, we saw this before. Over time, there's a convergence. So the UK audit program saw the standard deviation drop from 3% to 1% over 20 years. It's kind of beautiful. This is showing is that the audits are working. We're getting closer and closer. We're converging upon the same value. So then that means that a treatment in Kenya is going to be the same as a treatment in Gambia, is going to be the same as a treatment in Morocco. So that's beautiful. That means that that the literature that we share, the literature that we read is universally applicable. So the audit's compliance is now part of trial credentialing and even national quality standards. These things they improve outcomes. And this really correlates with better treatment consistency. And I mentioned that before, the 5%, the ICRU 5% rule. Well, maybe now it's time for 3% rule, because we've gotten better and more. I don't think we're going to be able to completely get down to a 1% rule, but wow, that'd be cool. So this is the conclusion. So the key takeaway: the reference dosimetry provides the foundation. Audits provide the safety net, and both are indispensable. Don't wait for something to go wrong. Audit yourself today. Audit yourself annually. And then that quality control, that quality culture, calibration audits should not be. They should be ingrained in the department's routine. They should not be seen as extraneous. They're not something extra. They are something integral. They're something that we should always do. And there are a lot of different ways to do them, but it's setting up that system. And there's a bunch of these. Hopefully you'll have this presented to you. There's a lot of reading material on this. You can dig as deep as you want, go down the rabbit hole. That's it. I want to thank you for your time and attention.